So the more we can open this up to communication and to just discussion, the happier I think everyone will be. So as we get going, just please know that this is a conversation. If you have something that's not making sense that you want to contribute to, please go ahead and unmute yourself and jump in.
And then Elizabeth Martinez had asked, are you going to cover how to work with a land contract?
There is someone with their mic off right now who might want to put their mic back on mute.
Oh, Lisa, I just muted you too. Sorry.
That's okay. I probably need to be muted.
All right, we have 30 people here, but we're waiting for like hundreds. So
yes.
We got to keep waiting.
Yep.
Also, yeah, let's interrupt.
Yes.
Let's interrupt each other today.
It's how good meetings go, right?
Yeah, I know, because you have to speak. You're so passionate. You can't even imagine not speaking.
Yes. So we will, Joanne, I'm going to let you tell me when it's time to kind of get going as we kind of move forward here.
For all of you intrepid people who came early, one of the things that you can do in the chat is put in any suggestions or requests or things that you really wanted to take away from this meeting so that we'll remember to kind of build it in either to when we're talking or when we're chatting in smaller groups. So if there's any burning things that you really want us to try to get to, let us know.
Excuse me.
I think people are just still trying to get from one meeting to another.
Yep.
Our numbers are not there yet, for sure. Thanks for coming, everybody. We're still waiting for 70 more people. No worries.
The bus is running behind schedule.
Yeah.
That does happen, doesn't it? A few more there. We're starting to see a few more people creep in there.
Yep.
For those who are just now joining, go ahead, welcome, throw your name up in the chat and tell us who you represent so that we can have a better understanding as to who's out there. We are going to give it a few more minutes. We're still waiting for a few more folks, so we will get going shortly here.
No coughing.
Sorry. Isn't that what everybody's doing right now?
Oh my God. Every time my kids make any noise, I'm like, why would you do that?
Don't be out somewhere and sneeze. It's
no.
Yeah.
Yeah, I think we're going to have to give it like at least 2 more minutes, Lisa.
Okay, that's fine. That's fine.
Hoping
and again,
the invite.
As the new folks are starting to come in, take a moment, introduce yourself on chat, and any burning questions that we absolutely have to get covered today, any burning kind of topics that you want to make sure that we cover, throw them up there so we can meet your needs.
Oh, Dr. Klinkman, I see you talking, but I don't see.
Yeah.
Yep.
Just, are we able to delay our move to groups by a couple minutes since we're starting
Sure.
late?
Yep.
Okay, we might want to do that. because I suspect there may be some conversation to have with the first session. So,
Yeah.
okay.
Thank you to those folks who are throwing their names up there. That's great. Thank you. And I know that I've said this before, so the people who are like, who have been on here for a while are going to be like, shut up. But this is a good discussion. This is not a one-way conversation. We want you to take your mute off, participate, interrupt. This all goes so much better when we can just have an open dialogue. So as we are moving through both the first part as well as the breakout sessions, the more people engage, the better this will go, and the more we learn, to be quite honest. Seeing lots of folks coming in. Welcome.
Yeah, I don't know how much longer. I think maybe we should get started and see, by the time we get to like the meat of it, hopefully we'll have a quorum.
Okay. All right. So with that, we're gonna get going, and I'm gonna take a minute to introduce myself. My name is Lisa Nicolau, and I am the MyHIN Social Determinants of Health Program Director. Relatively new position here at MyHIN, but certainly done with the idea that there's a lot to dig into when it comes to social determinants of health and the data surrounding social care. Next slide. I think you can see on our agenda, actually, you can see that we're going to start with just a group presentation, just kind of some background and some purpose as to why we're here, what we're doing. And then we're going to kind of make the bulk of this really about small group conversations, and try to take the bulk of that time to really facilitate good conversation, really understand what's happening in your world as it relates to social determinants of health and social care data. And then we're going to come back together kind of just for a last powwow and figure out what those next steps are. And again, the more you engage, the better off this conversation is going to go. So we look forward to your comments and feedback. Next slide. So we are going to, you're going to hear and see these folks throughout the day. You see a lot of them up there now. Again, this is a team effort across the board. We have a lot of people digging into this. And as we get into breakout sessions, you'll be able to get a closer look at each one of these individuals who bring their talent, their passion to the work of social care and social care data. Next slide. So the other thing to really keep in mind is although MyHIN is one large entity, we are looking and we have dug into this with great partnership. And as you can see on here, we have lots of people within the community that we are constantly going out towards and trying to build that network within the community, across healthcare, across government entities, across social care entities, to really do this in collaboration with and really work towards a future that is bright and based on partnership. So these are the folks who have been willing to engage and really partner with us for this specific set of workshops that we have done. So thank you. Next slide. Why are we here? So the purpose of convening all of these groups and is to really kind of engage in a series of conversations to identify those barriers that happen with cross-sector care and data exchange. And when we mean cross-sector, it's really, have identified as it relates to social determinants of health and social care data, that data does not reside just in healthcare, does not reside just in community-based organizations, and it does not reside just in government entities. each one of those sectors has a need for, and on a daily basis utilizes the data that comes from all of these different sectors, and how to get that to them in a way that does not increase their administrative burden and increase the workload that they have to do, because let's face it, we've all got more than enough work to do right now. So really trying to facilitate that conversation and identify barriers and a path forward as to what that would look like. And it's a concentrated opportunity amongst all three of those sectors of care to provide that feedback towards a statewide social care data strategy that will emerge. Any questions about our purpose and why we're here? So I'm going to introduce Joanne Jarvie. Joanne Jarvie is our Senior Director of Outreach and Market Communications, and she has words surrounding this next slide. And I wanna let her take this one because she brings the energy and that to this next piece.
Okay, so I do want to level set around MyHIN, like, and sort of what we are and why we're here. If you guys have never heard of us, that's because they didn't have me, but now they do. So MyHIN is the Asian network shared services. We are the digital technology. We are the digital infrastructure that undergirds sort of health exchange in the state, right? When we talk about infrastructure, we have like roads, we have bridges, sure, we've got pipes, but you know how exciting digital infrastructure is? Super exciting. You need to have routes that make sure that the appropriate data gets to the appropriate party at the appropriate time. And sharing that data is bound by all of these legal agreements. And our state has invested in MyHIN as a sort of routing and structuring and standardizing mechanism for sharing data. But what is data? You know, data by itself is just not, it's not communication. It's not relationship. It needs to serve, you know, human beings doing their jobs. So I want to be clear that technology, we're going to be talking about data sharing, and we're going to be talking maybe about the technologies to share data. But the most important part of this conversation is like how people work together to make other people better. And then using what we understand about the way humans work together to influence how we share the data and how our technologies should be speaking to one another in a market-driven system. MyHIN is a nonprofit. We do not produce healthcare services. We don't produce our own healthcare data. We are not competing in the marketplace. We are here to connect legally and securely and with human beings' privacy in mind. Does anybody have a question about this slide or about MyHIN at this point? Great. Okay. I did it. Did my job.
Awesome.
Lisa, let's keep going.
Thank you. So just a summary of who had signed up to attend today. I think we've got a few less folks here, but clearly it shows a wide interest across all of these agencies into what is happening when it comes to social care and social determinants of health. So just a really a great summary of attendees. And just for your information, during our community-based organizations workshop, we had over 130 participants. In our healthcare provider workshop, we had over 180 participants. So again, adding that to where we are now. And I will say that this is our first real foray into kind of government entities and how does that impact within this world of social determinants of health. So kudos to everybody for joining.
That we like kind of saved the best for last, and I swear I didn't say that to the other two. But you guys are boring and we don't care. But for the government entities, we have so many questions. There's a lot to learn because there's just a lot of disparate uses and purposes for everything that you guys do. So this is really going to be, I think, the most interesting one.
For sure. Next slide. So certainly within the healthcare field and even a lot of the community, people have seen this slide. They get this and they live it. You know, what this slide really says is there's more that goes into somebody's overall health than just healthcare. Healthcare, as it sits, really only about 20% of somebody's overall health, whereas things like health behaviors, their physical environment that they live and work and play in, as well as those socioeconomic factors, really contribute the vast majority of what contributes to health. So when we look at improving healthcare outcomes, we really have to focus on more than just healthcare. And again, this is something that most people, when they live it, they breathe it, most people get this. So it's good that it's now kind of out there and much more prominent. Next slide. So let's clear up a little terminology here. So social determinants of health, everybody uses social determinants of health as a catch-all phrase. Social determinants of health really references the environments in which people live, work, play, all of those environments that impact their health. The data of social care can help to identify what's important, where those disparities that impact health are, and how to improve them. When we talk about the data of social care, we're really talking about things like social needs screening. How do you identify a problem that exists or identify an area of a problem that exists? How do you get to something a little bit more specific than like a big gigantic area like food insecurity? Food insecurity can be as wide-ranging as I'm, elderly and I can't get out to the grocery store, or I don't have enough money to go out and purchase food, or I live in a food desert where the closest place that I can get food is the gas station. So there's lots of different ways to be able to get down to something much more specific, and that allows whatever interventions that happen that are meant to resolve that need to be very specific. And having data in our communities and as a state as a whole allows us to target those interventions a little bit more specifically. The other piece of that is what happens to that. How do we get that individual from one organization to another? All of these pieces of data are really what we're talking about when we talk about capturing that data. All of that data feeds the environments and tells us more about the environments that people live in and how those environments can be improved. Does that make sense? So when we think about social determinants of health, we use it as a catch-all phrase, and I don't know about you, but my mind blows up when I start thinking about how do we capture data about environments. I get a little shell-shocked. So next slide. So my end goals for the SDOH program. So when we start talking about cross-sector care, we really have to kind of make sure that we talk about this from two different perspectives. One is that idea of supporting care coordination. We all know, just as Joanne said, that this is all about human interaction and how do we get people, who have been able to identify a need that they have, how do we get them to the people that can help them within the community, those social support systems within our communities that exist right now? That's one piece of it. And how do we make sure that healthcare or government entities all stay abreast as to what's happening as that need is being resolved, or maybe it's not being resolved? All of those things play into that cross-sector care coordination. But then there's a secondary purpose for that data. And that's that purpose of data where we say, okay, let's take a look at this. And where are we with this? Do we have enough social support within the community? Are there areas that are nobody can meet that need because there's no resources within the community to meet it? How do we utilize that data to then restructure and make things better for those environments? So providing that comprehensive data for that population health improvement perspective as well. So MyHIN is doing this by developing the pathways, as we've done within healthcare, and creating those pathways for data to flow. We're broaching that within the social determinants of health program as to how do we do that and develop those exchange standards for social needs screening, social problems, which are in a healthcare world called diagnoses, and social interventions. What's being done to actually meet that individual's need. Next slide. So how on earth did we get here? And I think we're going to spend a little bit more time on this because this may not be as familiar for folks as maybe within healthcare or within social care themselves. When we start looking at how social care became such a factor here in Michigan, we really have to go back quite a ways, to the point where we started to think about healthcare and go, geez, we're paying a lot for healthcare, right? We're paying a lot for healthcare. How are we going to impact the costs of healthcare? Lots of quality improvement processes, trying to improve the data of healthcare in order to understand what's happening within healthcare. And through all of that, we've started to evolve these new models of care, models of payment. So these value-based partnerships, where we're moving from see one, do one, get paid for one, which is that traditional fee-for-service model, to something that is more structured along see one, do one, get paid because that patient actually has health outcomes that meet, a good quality. As that has happened, as healthcare has moved from that fee-for-service to fee-for-value model, more data is becoming aware, and we're finding that, there's a lot more that goes into healthcare. Remember back to that very beginning slide where we said there's a lot more that goes into healthcare than just, medical care. So that's where we started to kind of really bring in community. And back in 2015, 2016, when the state innovation model and the blueprint for health within the state started to emerge, it really focused largely on the community. It brought in these community health innovation regions. In our state, there were 5 that were surfaced, and they were meant to act as accelerator units to see if bringing in social care could really influence healthcare costs, healthcare delivery, and healthcare outcomes. And what did that look like? And those accelerator regions did just that. There were good outcomes that came from that, but there were also significant issues that we found as that state innovation model played out. Towards the end, as data is starting to be collected, we're recognizing that there's not a standardized way to be able to talk about, categorize, standardize that data of social care. So things like the Gravity Project started to emerge. I'm not going to get too heavy into the Gravity Project because I think Dr. Klinkman's going to go into that a little bit later on, but that's a national unit that is meant to do just that. It's to standardize how we describe and talk about social care so that it can go back and forth between all of these different sectors of care. So lots of good learning, lots of things that are coming up, but we're recognizing that there's a lot of barriers that are going into this. Sorry, go ahead.
Sorry, Lisa. See, I interrupted you because okay. I'm wondering, I'm interested to see if the participants, maybe you could raise your hand or put in the chat. Are most of you familiar with the state innovation model with our 5 shires across the state? Or are these new words to you? I see some hands. Good. I see some of that. Familiar. Good.
So that's
great.
Good.
Yeah.
So we've got, 5 regions right now. We've got other regions that have really emerged as time has gone on because they've seen the value. Communities are starting to self-organize towards this. And we're seeing that play out. And again, Dr. Klinkman may be able to speak more to it. And then, right as we're starting to kind of gain some momentum, then we see things like COVID happening. And the pandemic really highlighted, and I think we can go on to the next slide there. The pandemic really highlighted and the divides that we all knew existed, but it turned a microscope on it, and it showed us how those health equity gaps really played out. So not just within social determinants of health, but within health equity as well. And the pandemic, I think, has been the great awakening when it comes to this. So what that pandemic has done has accelerated the urgency and the demand for this type of data, because people are turning to it and going, oh my gosh, we've really got to get on this. So it's increasing the demand, increasing the urgency, which puts us all running at breakneck speeds. So what we really want to do is create the conversation that helps to steer us in the right direction. Next slide. I think this is where my good friend, Dr. Mike Klinkman, takes over.
Thanks. Thanks. Hi, everybody. For those of you that don't know me, I'm Mike Klinkman. I am a family doc, first and foremost, in Southeast Michigan. I'm a professor of family medicine at University of Michigan. So I'm coming at this from kind of the opposite pole that a lot of communities come at it. So we're having this conversation in honesty to try to reach out and learn from you all how this kind of sits with you. And my job in the next 10 minutes or so is to do a really quick flyover about how MyHIN is approaching this huge problem of sharing care. And this slide shows the basic strategy. We want to build on a foundation of a common care model, and I'll show that in a minute, to support caring for people when that care goes across the medical and social and mental health boundaries. We want to work with the National Gravity Project, which is a big collaborative that's trying to create standards, ways that everybody can agree on to both collect and share information and make it interoperable. That's about all we'll say about that at this point. We're going to use the tools that MyHIN has built to serve medical information exchange wherever we can. We're going to leverage that as best we can. And we want to work with vendors because we know that many of you have already begun to work with vendors that do some of your information technology support work. We want to work with vendors that are willing to build to these standards so they can talk to each other. Next slide. This picture lays out the basic folks participating in this work. You can see, the three you think of right away are at the top: patients and clients and doctors and affiliated healthcare providers and social services providers. But the other groups are largely hidden from this work, and that's mainly where you sit. And we want to make sure that we get that perspective in this work. Next. And I'm going to show a couple pictures that give a really humble analogy of a stool that has to be sitting on some standards, on some supports. And one way to look at this is that there are 4 sectors that are engaged in what we call a community integrated health network. And that language comes from the Administration for Community Living. And it's a way that everybody in a community, all the sectors, work together to improve the health and the well-being of their residents. This is what we called a shire in the SIM demonstration a few years ago. And those of you that don't know anything about SIM, we'll talk about that as we go through the next few slides. DHHS is now using some different terms: health equity region, health equity districts, with a real focus on making health equity a reality. And the sectors are public health, the healthcare delivery system, social care, and government. And that's where many of you come from. And the next picture kind of goes into the nuts and bolts of how we see this stuff fitting together. And there will be a quiz on this at the end. So I really want you to put this in your head, because you can't get off this talk until you tell us what the slide means. This just shows the building blocks that have to kind of be in place so that this can work. And you see those same sectors are on the side. It's, what does government do? Well, government governs this, kind of guides it, kind of helps develop it. They align the stakeholders so that they can work together to a common goal. The government often is responsible for resource allocation. How do the resources that you have get used? And aligning the policies so that everybody's working to the same goals. The other sectors have their own roles. Healthcare does screening more and more, and they do care coordination for people with complicated needs. And now we're asking them to do referrals so that they can communicate better with social care organizations. But the highlighted things, where MyHin's lane is in this picture, is in helping to put standards in place so that this work gets easier, and helping to build the infrastructure, not just the technical stuff, but the human stuff, so that people can work together to a common goal. And without the infrastructure and without the standards, this thing doesn't hold together very well. So that's our lane. Questions about that? I know that that was just a lot to throw at you, but it shows the place for government and other stuff in what we see as sort of an all-play exercise. Yeah, Janine, that's a great comment. Community development sector is often left out. They're part of, I think they're part of government, and they're kind of a hybrid of social care, government, and public health. And in some communities, they have been a really core driving force for getting this to go. Like you have in Detroit. We'll talk a little bit about Washtenaw maybe in a minute. Okay, let's move on then, in the interest of getting to our talking to each other. These are, MyHin works in use cases. We create scenarios so that we can work on how information needs to move and people need to collaborate. And you'll see on the right of this picture a lot of your stuff, right? Reentry, people coming in after they've been incarcerated or in correctional systems, trying to build aging in place capability for people in communities, working on identifying and serving children at risk when they're primarily in the educational system, not necessarily in the healthcare system. Refugee resettlement, really hot right now. So the use cases aren't just, let's help somebody who's coming in to see me in my practice get housing support. It's a lot more big and complicated than that. You probably can all see your particular favorite use case in this picture. If you can't, let us know, we'll add it. Next slide. This is that thing we talked about called a care model, and it shows in general when care for a human being goes from one sector to another, you got to work together and the roles are complementary. In this case, if somebody comes into my practice and is screened for social problems, I might be able to say, okay, I understand you have this particular social problem. I can't provide care, so I need to connect to community services to do that, but I don't know necessarily what they are. So I need help. I need a way to get to those services, and that for my patient to get to those services without a lot of false starts. So the complementary roles are built into for most of this stuff. And that's where the cross-sector care and communication has to be built. And we have only recently figured out how complicated that is. So we want to make our tools simple. Next. This is how it would look for one of the use cases that I think is more germane to you guys in this audience. School-based screening. So you could identify things you could do in a school district to screen young people, children and adolescents who are at risk for specific problems that may not be known. There are many instruments out there. There's the ACEs, there's social screeners, there's mental health screeners that work for children. And if you identify a child who has a potential problem, you need to better assess that. And schools are getting better at doing that. But when it comes to providing services for those needs that you identify, schools often need help that they can't provide internally. And that's when they need to connect to community, to behavioral health resources or to social resources. And somehow kids need to be followed so that we know that their needs are met. And again, that's a balance, right? That's a complementary role for the educational sector and for the community and healthcare. Last picture before we dump this topic. This is actually something that we designed and began to build in Jackson County, a specific program to screen children and adolescents, to identify their problems, to figure out whether they could be handled through the schools or whether they need to be referred to community. And we used a community hub that we built in the SIM project to be the place where those needs got triaged. It was a very ambitious project. It's just only now getting kind of worked through, but this is an example of how these use cases can show us how to move information and get people to work together. Okay, next slide. These are some examples, and I'm not going to go through all of them, but we are working. Yeah, George, yes. ACEs is adverse childhood experiences. So these are some examples of how we're starting this work carefully, learning from all of you as we try to do these things. I'll point to a couple. In several counties and with the Michigan Department of Corrections, we've talked about how to build support for re-entry programs, because the connections that you need to make are huge, right? Housing, employment, social services, healthcare for some people, substance abuse disorder care. And too many people coming out of incarceration or coming out of the correction system need to be connected all at once to all that stuff. So we've talked in Washtenaw County about how to maybe build a support system where we can help provide the infrastructure to connect. Down at the bottom, we'll take top and bottom. The Washtenaw County OCED, I think Moon's on this call, there's a community hub that they are building to organize community organization and community development organization services through OCED. We've talked about that. We can link that group to an already existing community hub in Washtenaw County so that the community and the government sector can work together to meet complex needs. This is new stuff. This is not being done well elsewhere, or it's being done in an isolated way for a specific use case on a specific pathway, but it isn't built to connect to other work in a community or in a region. So it's huge work, and we need your help to do this kind of stuff. All right, I think this is the next slide's the last slide before we kind of get to talking with you. Yeah, these are the challenges. We're finding more bullet points day by day in this work. But the biggest ones for you to know is that we're trying to establish a shared vision for how this care could work across sectors, where we're all working in our silos day to day. We need to just lift our heads up enough to understand how to connect to others, and it's hard. The concepts of data exchange, community information exchange, cross-platform data sharing, all that stuff's necessary and all that stuff's hard. And then keeping people aligned across sectors and engaging the stakeholders to talk about this is pretty important. So this is where we're at. And we won't even go into the stuff that would be your advanced graduate level course on data governance, data stewardship, who owns the data, how do we share it? That'll be for another time. But we just want you to be thinking about why it's good to do this stuff and how you can contribute and what you can teach us. And with that, we go to the next slide, and I think we're ready to move into some real conversation. So back to you, Lisa.
I did want to kind of highlight some of the comments that I'm seeing in there, specifically regarding the school-based model. And I think what I'm hearing and seeing is that there's a lot of work that's already going on to be able to kind of to think about this, and hopefully the timing is right to kind of connect on a different level and do it with standards that allow that data to go more than just within a regional approach. And then can you share the Shire evaluation that indicates the successes that were mentioned? Yes, I believe that we can. And we will make sure to do that.
Yeah, it's interesting because, like most things, the Shire evaluation was focused on primarily a healthcare use case, which was interesting. And it showed that the demonstration saved money for healthcare. But I think some of the other outcomes that we're looking at are broader outcomes, and we haven't figured out yet the best way to start to measure those. It's another thing you can help us with is, what are the measures that really matter in this space?
So are there any, before we kind of move on to these facilitated discussions, does anybody want to say anything about kind of what they've seen so far and how they're thinking about it? Any comments? And just feel free to unmute yourself and chime in. All right, if not, then we
got somebody. Hang on.
Is somebody
Yes, sir.
saying something?
Yes.
Oh, I was just thinking this the other day. One of the challenges I think that's occurred during the pandemic is in the system that we currently have, which is not a community care hub whatsoever at this juncture. But one of the challenges we face with the pandemic is that we utilize a direct emergency assistance module to help out folks for like utilities or housing concerns. Is that there needs to be something that also sort of can manage the impact onto the social services network, basically because the amount of like requests and funding that we got tripled between 2019 to 2020. But that put a great strain on all of our agencies that are doing intakes and doing screenings, and that's continuing to this day. And so in these systems, there needs to be some type of feedback loop so that the funders can also see like, oh, hey, yeah, we want to offer these more services, but can the network really absorb it? That's all I want to say.
Cross-sector care 202, not 101, but it's exactly right. And when we've talked to community organizations, a lot of the feedback we get is, we need this information so that we can show the value of what we do, so that we can also identify when our resources are being stretched or strained, that we can provide service, but that we need more support and able to do that. And somehow the sort of grand accounting in a population health way can be carried out with this work if it develops to a certain point. Great point.
Really great point. Anybody else before we move on?
Yeah, there's a comment by Monica here I think is important. Racism is a really significant social determinant. Yes, we're trying to be very careful in how we approach this, because what was originally envisioned as just a way to standardize data to move it, we realized that we weren't addressing disparities in care that can occur along racial lines. It occurs along urban-rural lines. It occurs along SES lines. And so to call out racial issues is really important as well. It's a little hampered and a little harder because it's just such a sensitive topic. And the infrastructure we're trying to work with everybody to build will allow us to identify places where systematic racism gets in the way of doing this work, where resources may not be available to people of color in the same way that they are to people who are not of color. And this is sensitive for who? Great question. I think it's sensitive for everybody who feels as if they are doing good in this space and finds their initial efforts that are flawed and imperfect viewed with a lens that expects that we're going to solve these disparity issues in one leap. So it is intimidating for some groups to take the plunge to try to work on this for fear that their efforts will be disparaged or called into question if it doesn't solve everybody's issue right off the bat. This is really, really hard work, and it threatens the work. So I think one of the things we have to do is give ourselves a pause and a pass as we start to do this, saying we'll evaluate it, we'll see where we make progress in racial issues or we make progress in other disparities, and then double down where we haven't made enough progress. But that requires that we evaluate this stuff and that we implement stuff.
And Dr. Klinkman, if I could add, one of the things that MyHIN is doing specifically is we're starting to facilitate that transfer of screenings. And as Lisa talked about in the beginning, there's the two different ways that data can be used within our use case. One is to actually help that person get their need met, and the other one is for population type reporting. And while this isn't going to be a silver bullet or anything, but it is, we are capturing a number of demographics like race, ethnicity, gender, some other factors, county, and we can start to look for disparities of, like trends of needs by different demographics, so that can be surfaced to those that are managing programs and say, there seems to be a significant need in this particular area, so that people who manage those programs can take advantage of that information and improve.
And there's another cautionary tale here that we can tell from work in other states. And if you do this work of trying to combat racism or being anti-racist directly, sometimes the motivation and the language is itself creating more of a divide. People talk about targeting, and it's almost like profiling, when you're trying to find risks. And some of that can be good, but when it is done in a way that, again, isolates and sets off a racial group, those groups themselves have pushed back against that. And so this will be an implementation issue that we'll be talking about probably for the next 2 years to get it right. But thanks for bringing it up. That's really important.
I don't want to curtail the conversation, but I do want to move us into our facilitated breakout rooms, where the following 3 topics are really we're going to try to break into it. And I think some of that conversation is just going to extend into those breakout rooms. So I believe Caitlin is going to just magically move us into our breakout rooms, and we will meet you all there.
Yep, you're correct, Lisa. So some folks will actually just be staying in this main room, but half of you are going to get moved to a breakout room. So you should be seeing that happen shortly. You don't have to do anything. Just give us a minute and you'll be automatically moved.
I think that this may be the group that we're going to have here. So what we're going to do now that we're broken out is we're going to go through a handful of topics, and then we have a couple of questions in each topics grouping. I can go ahead and share my screen with those questions. And the intent of what we're doing right now is we're trying to gather information. We're trying to make sure that we have the right type of direction. We have the right feedback. And so we're really going to ask you to engage in this part of the conversation. Feel free to unmute and speak at any time. Feel free to use the chat, and we'll try to keep our eye on that. We're going to be going through these 3 overall topics here: collection and sharing of social care data, referring individuals in need, both the workflow and the process, and then talking about organizational capacity. If you do have thoughts that are related to the topic but not directly addressing the question, that's also welcomed as well. So the first question I've got for everyone is, do you see a need for gathering, using, or analyzing social care data in your organization?
Hey, Mike, I'm here. I'm gonna just start like seeing what plays here. I mean, so when we talk about gathering or or sharing social care data, I mean, do the people here today have a system specifically to collect this type of data? Or is this, I mean, is this new to your organization? Are you guys just starting to screen? Do you ask questions about people's environments, but not put them into a system? You know, like what do we have here?
This is Janine. I guess I can go first. So we use the Prepare screening tool.
Yep.
And we're small, so we don't have a health system, but we are using Monday.com, and have created the form in that system, and we're collecting that and using that social care data.
So the Prepare tool is a very powerful tool. When you collect, so what do you do with that information after you collect it?
Yes, we use it to assist with our what we call care management process.
Yes, tell me more.
I would have to say currently about maybe 80% of what we do is resource navigation assistance. We are moving towards more of a care management system so that we can begin to address, help folks address root causes. And the data actually has been very helpful in helping us to assess what are the needs in our community. As a community development organization, we're place-based. So it's really helping us to better understand the residents whom we serve and can help us to come up with, or at least we hope, come up with more innovative programs to address those needs.
Tell me what entity you work for.
Genesis Hope.
Okay.
We are a community development organization in the city of Detroit. We serve residents on the east side, neighborhood called the Villages of Detroit.
Okay. When you you give people information, you were saying that you did a lot of information and resource navigation. So where did you look to make sure that like you knew where people could go, or if there was capacity, within the places to send them? Like, do you use 211? Do you have your own binders? Do you know your own people? What's the process?
Yeah, it's a combination. So we are a My Bridges community partner.
Yeah.
So we use My Bridges resource navigation, which is 211 data. But we also Blue Cross. I get them mixed up. Blue Cross Network, BCN. They also have a resource directory.
Yep.
And then we have our own book.
Yep.
Because we are continuously vetting these different resources and trying to keep our own list up to date.
Right.
That is the problem. That really is the problem with all of the systems that folks can.
Oh, I lost you. Did anybody else lose?
Yep.
Oh no. But yeah, that is the problem. How many systems? So right here, it just seems like Janine, Mike, for our notes, is working in at least 4 different systems, which is just not effective. It's not optimized workflow, to say the least. Certainly one of our goals is to make sure, Janine, I wish we hadn't lost you, but one of our goals is to try and make it so that these systems can talk to one another and can match clients or patients or care seekers across the continuum, so that you're not consistently re-entering information or re-screening the same person. Does anybody else, can you tell me a little bit more sort of, where does screening fit in for you? Do you use the data to say how effective you've been? Do you know, how what you do impacts your clients? And do you know how it impacts their health?
So I would love to go, because I come from a different sector. So I'm not health-based, I am youth-based. So I am a homeless youth community navigator for Montcalm Ionia United Way. So we are starting a pilot program for these rural youths, essentially just to work on identifying these kids. So I have deployed like a very large youth community survey that 1,800 kids responded to. I work through McKinney-Vento Kids, so I work through Kickstand. Yep. And then like the HDMIS system, but I don't personally have a hand in that. So ours is, because we're piloting and we're identifying kids essentially almost for the first time, we're sharing that data to our networks continuously so that we can bring in resources like transitional housing or shelters for youth specifically. So we're working in a capacity where there aren't resources. So for our youth, right, like this age group is one of the most underserved, that like 14 to 24-year-olds. So we're working to like pilot, build it, and to share that to our agencies, and just to share what we're working on, because there isn't really big, massive, like we don't do big screenings. I mentor kids. I'm just really just going into school and being like, I need you to report your kids so that we can like see what's going on with them. So we're doing a really massive community sweep just in identifying alone.
When you say that you're sharing with your network, what are you sharing?
So we're sharing, so we have through conferences and like community collaboratives and that stuff, just what we're finding. So like I'm starting a youth community collaborative, and today we're able to share how many kids are being finally reported, how many kids are couch surfing or are homeless, or all of that good stuff. So we're not sharing it through like a system, we're sharing it through each other.
Right. Okay. What we're trying to get to here is, does anybody in this group think, look, there's a lot of information that you can find out about somebody, and I don't need to know all this information to be able to serve them? Does anybody feel like maybe they don't want to be responsible for screening? They don't want more data? Or need more data? Because that's valid too. We heard from the doctors, you guys, by the way, like doctors are very busy people. We keep hearing from the health community, stop me if I'm wrong, Mike Taylor, but we've been hearing from them sort of like, we don't need to know that much information. Like, we'd like to know that our patients have been served and are being connected. But beyond that, there's not like a bunch of room, both like, I think, like emotionally and in their practice and in their workflows and in their EMR, to like know much more about a client. I guess what I'm trying to get to is, does anybody else feel that way? It's sort of like, we just want to give people food, or we just want to give people houses, or we just want to give people, their benefits, and we don't have a need for any more information.
But Joanne, this is Dave Lalamian, and I'm with the Area Agencies on Aging Association of Michigan. We represent the 16 area agencies around the state, and I would say from our perspective, it's not that we don't want or don't need additional data. It's that we have individual specific data when we encounter somebody that calls in or comes in, or that we identify as in need of something. But we don't collect and aggregate data on a network basis across all the AAAs. And, because we don't do that, it makes it challenging to, to integrate that with healthcare and with other sectors that might improve outcomes for the people that we come in contact with. So, we have some healthcare data that flows into the AAA network. ADT data comes in on people that are registered clients in the aging network, but the health systems don't get any data from us about social care or about the things that that we're providing to people.
And this is exactly, your use case is exactly what we are trying to move forward. I hear somebody else, and it's like a scratching. It's sort of like a mouse. I don't think it's a mouse, but it sounds like a mouse. But I think, so when you guys take in this data, it's coming from it's coming from your community partners, right? There are some agencies that are doing, that are getting calls directly, but there's also community-based agencies that are sharing you know, what they find back with you. And so we're talking about like the provenance, right? Where are people being screened? How many times are people being asked the same question? Do people find that? I'm looking at the chat, Mike. Why don't you take over while I try and make sure that we're getting to everybody in the chat? For information. Yes, statement of resources, right? So we know, like, who can we actually send people to for help? Who's at capacity? How do they define that? How do you know?
My name is Sue Latour. I'm from Harvest Time. I'm in Macomb County. We're in the poorest part of our area. We're just starting now a new program that's used worldwide, but it's called Link to Feed. And it connects people through all different resources. You can do an intake, you can update the intake. They can be at multiple different locations. Like I said, we're just getting started, but I'm really excited about all the data that it collects. And
you should be so excited. There is a pilot happening with Henry Ford and United Way of Southeast Michigan with Link to Feed that you should look into, because what they're doing is trying to get Link to Feed to connect to a hub, which connects to a hospital, right? And ultimately, that would be the goal, you know, I think in Macomb as well. You know, it's sort of connecting these disparate systems and making sure that the clients are being matched across.
Right, because we'll refer people to rental assistance, we'll refer people to My Bridges, we'll go through the computer and help them sign up. We do all that at our church, and the more resources we can get, the more we can connect them, the more we can follow up, and the more it ties them together, because it's all through one card, one number.
Right. Okay. But are you getting information? Are you collecting information about your clients, like if they have diabetes?
Yes, if they want to bring that up. It's diabetes, gluten, dietary requirements, because we're a full service pantry. We have meat, fruits and vegetables, canned goods, breads. So yeah, we like to know what it is that they need.
Mm-hmm. But do you share that information with other entities?
It's on Link to Feed, so if they go to another Link to Feed partner, they could see that. So if they walked into another pantry, they could see they came here, we helped them with clothing and coats and rental assistance, and now they're going somewhere else to get medical assistance. You know, we sign them up to My Bridges or food stamps or other resources. And then we can print off a report of whatever we want on the report.
Right. I think the goal would be to make sure that people who even aren't using Link to Feed could access the important information about that client, so that that client could get services from other entities.
Agreed.
Good morning.
Question. Good morning.
Good morning. My name is Lisa McKenzie. I'm Assistant Regional Planner with the Western UP Planning and Development Region, and I'd perhaps like to offer another viewpoint here. We assist organizations with their planning needs and planning for the future needs of our residents. For example, we just got finished with non-emergency medical transportation plan for the entire UP in coordination with the other regions in the UP. We use this type of information, the social information, but the only places that we were able to accumulate information was the ordinary census data, transportation data. We had none of the social data that might help with who's in need of transportation and from where, so that we could assist with a plan. And that's just a small example of the the things that we do. We touch base with housing, with pretty much virtually every aspect of living in a rural community. So I just thought I'd throw that out.
Thanks. Joanne, I didn't want to cut anybody off if anyone has any last thoughts, but we should probably move on to the next topic. So, looking at referring individuals in need, things related to workflow and processes. I think I really like the way the flow just went. We do not have to tie to any single question. We can take a look at these questions as thought provokers and go from there. So we'll start with, how does your organization refer people to services that you don't provide? And let's go from there.
All right, so Audrey said that they refer everyone to 211. So here's my follow-up to that. When you refer people to 211, do you know what happens after that? Do you hear back? Are you able to track sort of what, you know, what happens after? Do you have a system with 211 where they report back to you that they've been connected, or is it sort of just a place to send at this point, Audrey?
So it's dual. So our United Way has spent a lot of time and money to make 211 the main resource hub in our area. Again, we have like lack of services. So we're able to request from 211 if any and all data that they have. So if we have someone really specific that we're trying to make sure that we're targeting, we can go back to 211 and ask about that person. But we get pretty regular reports from 211 that shares everyone that's been served pretty regularly. So yeah, it's kind of both. But 211 is our hub for all of our resources. And we work pretty hard as a community to bring it all together so that it's all just in 211.
Very happy to hear that. Audrey, when you go back to 211, you say, I would like information about, what do you say? You say this person, you give them their first name, last name. How do they find the person that you're talking about?
From what I understand, generally it's that name and then maybe what their service was looking for, but that's something I would have to check further on into.
Okay. And Audrey, are you guys working in, do you have access? Are you working within My Bridges as well?
I will be honest with you, I'm not entirely sure. So we have like a local fiduciary that is called 8CAP. I know that they do for sure, but I don't know if our United Way does.
Okay. So when you say that you have a resource, so that as a person, as a human being flows through your community, are you able to see or know who's serving that one person at any one time? You could see from 211, you have that sort of relationship, but can you see from that other partner that you mentioned?
Yeah, we can. Yeah. So 8CAP does all of our housing and stuff. So, and all of our shelters and all of that good stuff. So through their HDMIS system, we're able to track all of that as well.
Okay. So you have access to their system.
I'm actually about to be trained in it soon.
Got it. And so how many systems will you then be working in, Audrey?
So about 3. So from 211, HDMIS, and McKinney-Vento.
Yes, thank you. Anybody have any more anecdotal, information like this? Sort of, how do you get people to services that you don't offer, and how do you know what happens when you provide that referral?
I'll just add that we try to follow up with the actual person after we've referred them somewhere. And then the process starts again. If they haven't received any resources, we look for some additional resources for them. And this is very time consuming.
Yes.
And we had good intentions, but we don't have the bandwidth. So we don't always get to follow up.
We understand. I mean, I understand completely. I came to MyHIN from a community-based organization, and I know that follow-up, that follow-through, the proactive work is intense and usually not paid for.
Yes, it's not. And with using the Prepare tool, what our plan is moving forward is for those, people will elect whether or not they want care management, and those will be the, and we won't continue to try to follow up with just folks who call up and say, hey, I need food, and we'll give them the list of places that they can go to, and then we'll close it, right? But for those who elect for care management, we'll work with them on a one-on-one basis and then ensure that they get what it is that they need.
When you're working with a client, do you ask them if they have doctors or if they have insurance?
Yes, we do.
Mm-hmm. And
we're partners with the clinic in the community that we serve, and part of our plan is continuing to strengthen our relationship with the healthcare sector.
Sounds like a sustainability plan. We like it. Yeah,
working towards it.
Anybody else doing their work in what feels like a silo, or it feels like you're working in a number of different systems and you wish that those systems were able to talk to one another? You need it on record.
Absolutely. When we are helping someone, like we've collected a resident's, name, all their personal information, right? And okay, they need assistance with their utilities. So now they've got to put that same information, or we have to put that same information in, because we deal with a lot of folks who are not computer savvy, nor do they have access. So we are completing these applications on their behalf.
Yep.
It would be a beautiful thing if I could push a button and, all of the information that we've already typed into, our system, we could, use it to auto-populate those fields where there is duplicates, and then only have to complete, information that we don't have, or yeah.
For sure.
I can definitely attest to that, working with Disability Network as an organization.
Tell me more.
A lot of the times, I am one of the case managers over there, and we assist persons with physical and mental disabilities with housing resources, transportation resources, employment resource, independent living, caregiving resources, and a number of other things. And I know one of the things that we do really struggle with here in Detroit with Disability Network is finding reliable, like you said, non-emergency transportation or housing that's suitable for us, or even being able to provide them with food or medical equipment and things like that they need. And I went from answering the phone and, doing the INRs, which is information and referrals, to doing case management. So I was able to see the difference between the two. And like you said, doing the case management and having to constantly go in and put in information, it's tedious. And then you have to put the same information in multiple times when, the organization is using multiple systems that, like you said, I feel like you should be able to click a button and, their information is automatically there, and opposed to having to go from one system to the next system, just to put in the same information. And it actually takes time from us being able to provide those resources to them, because you only get so long to do these things with them if they don't have a referral from an organization. And sometimes having to have referrals, it makes the process longer. And you are dealing with people that need help, immediately.
Right. Yeah.
And then I'm also noticing like a lot of the resources that Disability Network have been providing is, resource that's out of date. It's like now for me, and I do it because I am a person with a disability, so I know a lot of the struggles that they deal with. I go and do research and stuff on my own, or resources that different organizations have provided to me. I make sure that I provide it to those people in my community so that they don't have to suffer a great deal, especially being in a crisis like this pandemic. A lot of the time they are already in isolation and can't do much of anything because they are limited to their mobility. So I do try to make sure that I research helpful information and resources that they can use, today, opposed to having to wait 2-3 months down the line or what have you. Uh-oh.
Yes, this is not uncommon, but I thank you. I thank you for sharing. Donna, I would love to know a little bit more, if you would share about how the Hub Pathways model has been working for you. If you're still with us, these communities.
Yeah, I'm still here.
Hi.
I'm not the expert on the Hub Pathways model. We have a Hub coordinator, but I have been working with a steering committee, and we call it our North Central Community Health Innovation Region. We were not funded for that shire with the state, so we're following the Northwest Shire, which was funded, but we're trying to expand our community connections into some of the counties in the Central Michigan District Health Department jurisdiction that are part of that North Central Shire. And so that's been kind of my interest in coming here, is to find out, we really need a data sharing process. I know Jordan Powell's on here, and she helped develop a survey that we sent out to as many agencies as we could get to see, what people are doing as far as screening for social determinants of health, and, if they're using community health workers, or, if they're getting feedback on the referral process, are they collecting any data? And we found that a lot of people are doing screening, but then it kind of stops there and they don't really follow up and find out what happens after the referral. So that's a big issue. We're going to try to correct that. I know it's a big chunk to bite off, but
well, moving from screening and referral to actual social care, where people are getting served, and then you can see the impact of meeting needs, is like where we're trying to get to, right? That's like, this is this phase. So you did all this work, you gathered all this information. Who gets that information? I want that information.
Yeah, we have
shared it with your shire. You shared it with which shire?
Yeah, we have and Jordan put the link to the website. We have a platform where we have our data housed, and we have data for each county, and we kind of look at, like the number of referrals for housing, or referrals for food insecurity, or employment, or healthcare. And then we have information on, how many pathways actually were closed, that we were actually successful in completing that pathway. So we have a lot of good data that we can share.
Yes, but are people getting served, and are they getting healthier?
Yeah, I mean, we've had a lot of success in serving people. I have one kind of example that I love to tell.
Tell us.
That it's a one person, but still he's an example. But he came in and was screened for a heart health screening and had like super high blood pressure. So we referred him to our community health worker, and she did a social determinants of health screening, and he actually had no primary care provider, no health insurance. So she found him some insurance and got him in with a provider to get his blood pressure checked. And from there, he was referred to a specialist and found out he had an aneurysm, and he called us later to say thank you for saving his life because he actually got taken care of. So
wow.
I'd love to have more stories like that. But
do you guys work? I'm trying to figure out, are you guys working with, is this with Trinity? Is this through Trinity and Judy? Do you know Judith? Oh God, what's her name? She does this community pathways model. I'm just
Judy
wondering.
Bell at Mercy Health Muskegon.
Judy, yes, yes, she's the best. She knows this stuff inside and out. Is that who you're working with?
no, we don't. Yeah, no, that's out of our jurisdiction. We have Spectrum and Munson.
Spectrum and Munson. I like it. We are making connections here. Who gave me the Judy Bricknell name?
Christina Voss. I'm at Health West in Muskegon County. I used to work at the Health Project with Judy Kell. So
yes. Okay. But where are you working now? You're working in Muskegon.
I'm at Health West, which is Muskegon County's community mental health agency.
All right. And what's your life like?
So I'm a project manager in data analytics, and so I work with our SDOH data quite a lot. Muskegon was one of the state selected community health innovation regions.
Yeah.
So Health West was one of the founding partners in that group for the county. So they've been collecting SDOH data since 2015 or 16, and it's a standard part of intake and visit for us. So every time we see a consumer, they get screened. That is embedded into our current electronic health system. But referrals are largely done via telephone or paper or email at this point. So while we can capture our own data, there isn't, since the Shire funding ended, there is not cohesive data sharing going on across providers in the county anymore. And we don't have a way outside of people who are using MyHIN for referrals to track data as it's tied to an individual
right.
at a community level. So at agency levels, we can see data as an individual, but as an individual proceeds through the system, unless they're coming back and reporting it to us, we don't have data for them at every stop of the way like we do in healthcare.
Got it. Got it. Thank you. Somebody tell me more. Any other questions? Mike, what am I doing? Am I just taking this from you and ruining it? I always do that. I feel like we're learning a lot.
Oh, it's so ruined.
Ruined.
We're over time on this topic, but I was just going to let it go. I think organizational capacity, everyone's going to say they don't have capacity.
Who's got the capacity? Who's got the capacity and who's got the money? Well, I think I know some people who have money. But I feel like they're in healthcare, which is why we have to start connecting the dots back to the people that have the money. And the money may follow the data. So, yeah.
I just wanted to add that you mentioned it earlier, sustainability, and that is absolutely correct. In order for us to improve our services to to the residents, we need additional funding to build our capacity. And data for years now have indicated that what's over 60% of what constitutes good health are these social factors. And so the healthcare sector needs to, begin to pay its fair share of removing these barriers and reducing these barriers and resourcing the boots that are on the ground.
Yes, we have heard this. We have heard this.
And I'd like to add one other part to that, particularly for our community development organizations. This is a new world for us that we're exploring. And so where some social service agencies, they do know how to do medical billing and what's all required in that regard. A lot of your more grassroots social service agencies like the churches that are been doing this work forever, they don't know how to tap into that. And the same is true for community development organizations. I'm here trying to learn, how do we tap into that so that I can, cover the cost of my resource navigators and so on and so forth.
Let me ask you, did you find out about this through CDAM?
Yes, this particular forum, yes, I did.
Fabulous. Okay, good. So we went for the right partnerships, and yes, we believe that the capturing and sharing of the data, that we keep talking about this data. What does the data mean? What does it mean? Well, I mean, it could mean, a case for funding. It could mean a case for, effectiveness. It could mean new standards for serving people. It could mean making sure that, like, at an hourly basis, do you have the capacity to serve more people? When can somebody get off of your wait list? What happens to the people that are on your wait list? Are they still who is their care team, and who else is serving them, and how many times did they tell their story?
Yes.
All of that stuff.
For sure. And I am excited about, how community health workers, that there's new legislature, but it's still looking at them from the health lens and not the community lens. And I'm hoping that we can use this data and the partnerships with folks that are on the ground. What am I trying to say? That that the use of community health workers would become broader, and not that they necessarily have to be connected with, licensed healthcare care team. That folks can still get care and by a community health worker and be, reimbursed for providing those services.
Without being connected to a health system.
Or somehow helping us to make that connection.
I see.
Where you have, I've been doing research on the, performance-based pay and helping us make partnerships with the healthcare sector instead of the healthcare sector going out always and trying to build their own. Instead, that there's more incentives for them to partner with organizations that are already out here.
Right. But it's very hard to make those connections. I mean, if you see it from the other end, it's very hard to make those connections like one off, right?
True.
Like one by one by one by one, which is why, David, when we're thinking about the AAAs, I mean, this is the model, right? We have these, you need representation statewide and ways to connect, to be able to get to the ground, but also not one by one by one by one by one by one by one. And so one of the things would be, I don't think that Emily's in this talk But Janine, like, what would it look like if CDAM, right, were some type of hub, right, for community development, for the community development network? Do you see like where these hubs really come into play, or where a statewide system really comes into play? Because you can reach so many more organizations at, like, instead of trying to go to just, you know, make a deal with Janine, which I feel like we should definitely make a deal with Janine. Everybody on this call needs to make a deal with Janine. She's awesome. But like, but how many, you know, like we should be, there's got it there might be, you know, just, and that's what I think they did with the shires too. They were kind of like, let's look at these regions and then let's try and build. But I think the next move is to build out those regions to keep, you know, the tendrils, to keep weaving the thread to connect more. Janine, where is your closest hub? Is it Jackson?
No, so CDAD is our local Community Development Advocates of Detroit.
Yeah.
And then, you know, CDAM is the state level.
Michigan, right.
Yes.
But do you know, so, but are you, is your close, what health systems are your health systems? Just to.
Oh, well, you know, Detroit is crazy. So we have, you have DMC, you have Beaumont, you have Henry Ford. Who am I missing?
You work
and Ascension.
Do you work with the United Way of Southeast Michigan?
Not as much as I would like.
I have to put you guys in touch. See that there's stuff. People are building all these things, right? And everybody's like, oh my God, we're geniuses. We're building these things. And are coming in and they're like, don't even build it. We'll build it for you. But then what happens from a data sharing perspective is that we have all these disparate systems that have ownership of this data. And we have to move towards a place where the data is being shared for the purpose of active care.
Yes. We've been talking about universal applications for I don't know how long now. And I know Henry Ford Health System in our area is trying to lead the way in that kind of discussion.
They're doing really amazing work.
Yeah.
And they're connected to a number of different hubs. I just got so heated that I had to turn off my heater.
This has been a great conversation.
Let's hear, please. I know we're going to go back into this big room, right? And we're going to see what the other people were talking about. And I want to really impress upon you, if you have not heard, you know, what you came here to hear, if we are not going down the appropriate paths, please course correct us. We can't know what you know until you share. And we can't continue to leave out, you know, parts of an active care community. So like I said, people, you know, they're talking about healthcare. Sure, everybody talks about healthcare. Finally, you know, social services, community-based organizations, that's all sort of starting to rise into the vernacular. But then when we talk about all of the different systems and platforms that are used within government entities, you just add on more and more. Where are we on time, Mike?
Oh, we've still got 7 minutes left.
I would like to take these 7 minutes to do something a little bit crazy. I think people should start sharing out all the names of all of the systems that they work in. Put it in your chat. Tell me now. You've got you've got your tools, you've got your data capture, you've got your one-way data flow. Where's everybody working? Because if we have to call up those people, we need to get those people around a table and say, how are you planning on sharing the data statewide? Are you all offering me your systems? I don't see any systems.
Jerry from Single Family Living. I added mine's in the chat already.
Thank you. Yeah, somebody's super interested in our group here about Link to Feed. And again, Henry Ford and United Way of Southeast Michigan have a pilot going with Link to Feed. And this is, again, we want to highlight these innovations, and then we want to make sure that they are committed to being interoperable and that they are committed to feeding into the statewide strategy for data collection and data exchange. Link to Feed. Who else? Is anybody working directly in an EMR? There must be some of you working. PCE, yes. Jeff Chang. PCE undergirds all of the community mental health, right?
So
right.
PCE is about 85% of market share for mental health in the state, but not all of it.
Do you work in any other systems beyond PCE? Thank you, Christina. You've been really helpful.
When you say, how do you define work in? Because I mean, obviously being governmental, we're in all the state programs as well. Do you mean just for record keeping?
Like? Yeah, I mean, I don't understand. So how many times are you putting in information or extracting information about a human being that you're trying to serve during any one day?
I would say the bulk of the work that's being done now, we're actually in transition between EHRs. So in our current system until the 28th of February, not that anyone's counting, there are probably 4 or 5 systems being used. Some of those, a lot of those are actually internal, like access databases that we've built because of shortcomings with our EHR, our current EHR, that PCE will greatly fix. But more so, it's not so much data on the front end users for us, but it's the amount of data that we pull out of the back end and where that data goes as far as reporting and information sharing that's much more burdensome.
Right. So that's like the secondary use of data, right? That's at like the population health data. I mean, level.
Right. Right. And then there's also like our state reporting, and we have regional reporting, like for our PHP, and all of this data for grantees, as well as all of our billers. So it's the data that's coming out and spreading that's much more of concern at our agency at this point.
Christina,
yeah. Hold on. I want to add a layer onto this question, and that is if your organization is referring patients or people somewhere else, and if you're not using a system, if it is word of mouth, handing them a paper, call this phone number, whatever, mention that when you're describing your systems that you interact with.
Right. Anybody faxing? You know what? I mean, look, a lot of the best work happens because you actually know people in your community. So like the best thing in the world is having the relationship. That's how things get done. Hand out paper referrals to residents. Right. Right. And you don't know, a lot of those residents probably don't even have, like, even if they could, they probably don't even have the right access to be able to self-refer or self-screen or get into, you know, like you said, Janine, the systems that they need to sign up. Excel spreadsheets, right? Excel. Gotta love Excel. 15 out of the 16 AAAs are using Compass. So what are they doing? Are we talking to them? Can't they be better? Tech is a barrier. I know. It's not supposed to be. That's the thing. That's the kicker. Fix it, Mike Taylor.
I think part of the problem is that there's not a solution currently that's system agnostic. So what we found in the Shire work was if you wanted people to be able to easily share data, we had 27 agencies, and there's no way that you're going to get even half of them to agree on anything, let alone software contracts. And so if there's not a system that can't take in data agnostically, it's never going to work, which is why, I mean, I think is why people were so excited when MyHen started coming to the table, because we know how you guys are ingesting information, and it makes it a viable solution at this point.
Thank you. Do you want a job? You can't have my job. There's like, you could probably have Mike Taylor's job. Look, he's like hardly even talking. But yeah, so we're supposed to be vendor agnostic, right? We are supposed to be vendor neutral. We are supposed to have solutions and be able to get the data to move. And so these workshops are really trying to uncover all of the places, like all of the places that we need to be able to ingest and route and share legally.
Yeah, because I think the important thing is for the agencies, especially the smaller than that they are, is that you're not changing end users' workflows. I think a couple other women have said here much more eloquently than I can, is that we're all short-staffed right now, and the pandemic has made it worse, not better. And so the thought of changing somebody's tech workflow on top of them being overworked is just not a viable option anywhere.
Yes. Right. The solution is not going to be a vendor. The solution is going to be the collaboration and the sharing and the standards for sharing. I mean, that's what we think.
Yes. I think you're spot on, and you definitely do need to hire her.
Right? I know. I know. You know what? Actually, if it doesn't come up in that big, we have to go and be the smarter ones in that big group because it's just a big competition. So I think the way that you so eloquently really shared that it would be great to share again, because I bet that's what we found. And I hope they found it in some of the other work groups too.
I'm sure.
Do any of you guys, we have like the guy for AAAs here. How do, I'm just wondering if you directly connect to your AAAs for older adults and people with disabilities? AAA is amazing. Christina, where are you again?
We're in Muskegon County.
Great. Got it. There you go. You got the boss here, so.
Well, gold stars all around at that organization, please.
I love that. That's wonderful. Is anybody in touch with the, oh no, we're going to be wrapping up, but I'm just wondering also, is anybody in touch or working with or a part of the Senior Regional Collaborative? No, okay.
Well, I'm now on the Older Adult Advisory Committee for Macomb County, but my first meeting is today, so I'm going to be learning a lot.
Good, great. Yeah, I know that the state is really wanting, they have this health information technology plan coming out for the next 5 years of where the state should be going. There is a public commenting period. I think it's happening either today or tomorrow. But, you know, all of this work, all of your work needs to be considered. Lisa, how was your breakout?
Our breakout was good. How was yours? I saw all the comments coming through on your session. So
oh, I know. I was
like distractible.
Sorry. Yeah, we stayed in the main room.
No, that's awesome. So I'm hoping that everybody had really great and vibrant conversations surrounding this. So I think, you know, our goal in kind of bringing everybody back together was really to kind of figure out, you know, what are the next steps? Where does this work need to go from this sector's perspective? So we would love to hear from you. And I know that, you know, I think we should just open it up to a general conversation and figure out kind of what that next step is. Anybody from your group want to join in and weigh in on this conversation?
You know, we heard there was a lot of strong feelings around, you know, respecting the systems that people already work in, respecting workflow, respecting the lack of capacity, trying to make it so that all of this work is actually supporting the people that are doing the work and not taking away, you know, from the relationships that they're building and from the connections that they're making. And that, you know, MyHIN needs to remain vendor agnostic and vendor neutral, and that creating connections between the systems is important. A lot of people are working in 3 different systems, 4 different systems, resubmitting the same information, not being able to access a longitudinal record, not easily being able to match clients. Is that what you guys found, Lisa?
We did find some of that. Yes, we definitely heard the kind of multiple platforms and conversation coming through. And just, I think the value of the actual data itself for a lot of economic development areas and funders really came through. Yeah. Dr. Klinkman, what else did you hear in our session?
Looking at my notes, I think that what we heard was a lot of some concern about duplication of services and a lot of oblique comments about hard to figure out how to bring this stuff together and overcome those potentially duplicated services. So there's that's the public or population health function. And the people that were participating from a broader kind of county level were especially thinking about those bigger population health needs that could be addressed with better sharing of this information. And I think that was good. We didn't have to force feed that. That just came out. I thought that was good. The other thing that I was impressed by is thinking about something we didn't talk much about but was in the slides, and that's the area of environment and how environmental needs and public health impact is another issue, especially an issue that didn't come up as often in the shires because we weren't really addressing that. But we have to come back and think about that in a different way as we broaden this approach. So it should be obvious after the water crisis.
Oh, right, like access to clean air and water?
Yes.
Yeah.
Right.
Or yeah, and especially environment related to housing. We have a lot of examples of poor housing stock, mold, asthma, negative health impact, that kind of stuff. And I remember from the work we did in Jackson after SIN that we were trying to build out that public health intervention side once we could identify social needs, but the public health system, despite a lot of interest, didn't have the resources. So an important thing, and it reminded me that we need to better engage health departments at county levels to at least talk about this stuff. Yeah, Kate, same thing. Yeah, walkability, yep. Transportation, and just the distance engaged in some rural communities in transportation's needs, which isn't environment, but it sure is landscape. And we aren't going to go there yet because we don't have a fix, but yeah, these are important.
The other thing that I think kind of came out towards the end was this idea that there's interest and there's value in it, but truly being able to engage where like equity regions or kind of local organizations have not already taken up this work really require a bigger buy-in and of a different kind of lead agency to initiate and really proliferate the work.
Yeah, that came up for us too, sort of like when looking at like sustainability models. The question was like, so what are the people who have the money? Let's just say that there are people that have money. So are the people that have the money supposed to be doing deals with every single different, agency or group, or there's got to be a way to scale this, talking about network lead entities or hubs or using CDAM and then breaking it down which is why organizations like the AAA or United Ways or all of the places that interact with 211, getting that all those people at least under one umbrella. Stop! I want to stop.
So folks who sat through our session raised a bigger comment about 211. And I just wanted to say and then maybe we can open that up for a little bit more discussion, that as we see it, MyHIN, MDHHS, 211 is a critical resource for this work. That the goal is to make that resource directory more robust, more specific, and more accessible to all agencies so that we can better identify needs and serve needs and track what gets done. And there's a way to carry that out that 211 is very close to achieving. And for those of you that have 211s that are not as robust or not as well supported, part of what we're doing with the state is trying to figure out how to make that support more robust so that that is a key common resource for you all. We can talk about that again in the weeds, but I think that we're not forgetting. We want to take advantage of whatever is out there that you all can share. So.
I'll share something on that topic that really stuck out to me from our conversation. Was somebody was saying that it's not just having a directory of these community-based organizations exist and they generally offer this type of service, but knowing that they have capacity right now.
Yep. One of the so I'm going to answer that just and then I'll shut up forever.
No, you are.
The way we built the Jackson Care Hub in SIM was to track capacity. And so one of the features of the resource directory was current capacity of the resources that were online. So that we could then, if we were going to send a referral to community action agency, we get a notice saying, by the way, they're 3 weeks out and being able to schedule intakes. Because that was a way to do it on the ground that made it work. And so the resource directory plus turned out to be a great tool for us.
Catherine made a really great point in the chat function. Catherine, do you want to jump on and just talk about that?
Sure. So I'm kind of a little bit more in the community education sector now with Michigan State Extension, but I've spent the last several years in human services. And so it'll be a funder or an intermediary is what I was referring to, like LISC or something, for example, or NeighborWorks America in community development. They all have a system. So that's kind of what I was talking about, but I would find myself just wishing that, they would get together and collaborate, and seek to get more understanding of what it's like for us end users to be, trying to, multiple times enter the same information, which we talked about in our breakout session. And I thought one takeaway from the breakout was that the solutions are going to be in the collaboration, not in the, one system or vendor, but it's the community-wide collaboration.
Very much so.
Which is easier said than done.
Well, there's a bigger issue here, and I'll raise it. I'm breaking my promise already, and I'm really sorry. But that yes, as we're looking for funding nationally to kind of carry out pilot work for information exchange, we're running into the same question from funders like Robert Wood Johnson and other foundations. What platform are you building this on? And the answer is we're not building it on a platform. We're building something to connect platforms and communities. And for some reason, that statement creates a lot of questions and misunderstanding. And we're pushing this as hard as we can with national funders to say, what we don't need is picking fights about which vendor is going to rule every other vendor in this space. What we're trying to do is figure out how people can use what they have to connect. And that concept is really sort of hard for funders to digest because they want a product at the end of the funding period. So we're trying to figure out program, not project, and braided funding that goes on for a longer period of time so that we can do the work that we need to do without it being tied to, well, we're going to use Unite Us, we're going to use Signify Health, we're going to use Epic, because that is the wrong approach. And I don't know any other way to say it, but we just got to make sure that the humans can use the technology, not that the technology drives the humans.
I see some agreement there.
So after these sessions, this is the third of 3 sessions. We have been sending out the slides and almost immediately, along with the people who registered and attended, because it's important to see who else is like interested in this work. You know, like write to them or write to us, and we'll connect you. But we're going to be distilling this information, listening to all of the recordings, and creating, you know, a next step, an exhibit. Which we will also be sharing. I just wanted, you know, people are always like, will you share the slides? Like, yeah, but like, that's not going to be as useful to you as what we hope will come next.
Yes. And the recordings will be available of these sessions to reference back to. Once at the end of this week, we'll get out the slides to you. We'll get out the communication that has the information, as well as reference to our previous social determinant of health workshops that happened in 2020 as a lead up to this. So those things will be coming out at the end of the week, and we're hoping that within the next 6 to 8 weeks, we should be able to produce that kind of culminating white paper that really, you know, goes through all of this and kind of highlights the big issues and highlights possible next steps that we heard coming through these work groups. So looking at that, and then the recordings, as soon as we can, we will get those up and on our website so that you can reference back to them as well. So I think that we're kind of coming up on the last few minutes. Do any of the facilitators, do any of the note takers, do any of the participants have any last thing that they want to say as we get ready to close this session? All right, then. With that being said, I wanted to take a moment to say thank you. Thank you for taking 2 hours out of your day to be able to join us. This is really, like I said, our first foray into this government entity type of workshop. So your time is precious and your insight is precious. So thank you for joining, and we look forward to connecting in the future.
And find us if you want to talk about this in detail, kind of related to your own individual situations, because that's where the work really gets going. That's my experience around the country, is talking to a group that is local often moves this forward more than a big conversation like this. So don't
Most definitely. And I think someone had asked for all of the program team's contact information. Yep. When those emails go out, you will have our email addresses. So feel free. Doors are always open. Phones are always ready to be answered. So
almost always.
All right.
Buddy.
Thank you very much, everyone. Have a great day.